Good evening, everybody. Uh, at the onset, I'd like to thank all of you for joining this webinar and this teaching session. I know you've taken time off your schedules. Thank you very much. Mayank, am I audible?
Absolutely, sir.
And
You
can you
can
see my
take this.
presentation also?
Yes, we can.
Okay, perfect. So what we're going to discuss today is low back pain and a little bit about leg pain in the form of lumbar disc herniations and spinal canal stenosis. So low back pain is the second, no, back and neck pain are amongst the second most common reason why people go to see a general practitioner or seek medical advice worldwide. So the first or the most common reason why people go to see a doctor worldwide is upper respiratory tract symptoms, cough, cold, and the second most common reason is spine related problems. So it's either neck pain or back pain. So neck and back pains are something that general practitioners and orthopedic surgeons see all the time. And as spine surgeons, that's all that we see. So I'm going to divide this into three clinical scenarios. One is acute low back pain. The second is chronic low back pain. And the third is back pain radiating down into the leg. So the first one is acute low back pain. Very common scenario. Patients come with pain in the low back, maybe radiating down to the buttock, lasting for a few days. Does not typically radiate below the knee. Movements of the lumbar spine are painful in examination, and typically neurological examination is normal. Now, in the history, when you're speaking to the patient, it's always important to ask them to point out to where the pain is. Because when you ask them, do you have back pain? They'll say yes. And for them, the back may be, interscapular, thoracolumbar junction, or lower back. So it's very important that, what we think of as back pain is the same thing that they're trying to communicate to us. So ask them always to point out to the area where the pain is. And if they say they have leg pain, it's important to ask them to point out to the area where the leg pain is, because it may be just buttock pain, which they call leg pain. It may be posterior thigh pain, which they call leg pain, which they call leg pain. And these are not typically radicular pains. So radicular pains typically follow the dermatome of the involved nerve. So most of our lower lumbar disc pathologies cause pain going down below the knees. So this is acute low back pain, and fortunately it has got a very favorable natural history. The symptoms subside spontaneously in a majority of patients, and in these patients x-rays and scans are not usually needed, and the pain normally settles down very well with a course of non-steroidal anti-inflammatories and maybe some physiotherapy. Exactly what physiotherapy we prescribe, we will get to later. But just remember, acute low back pain is a self-limiting condition. Usually don't require x-rays and scans, and management typically consists of non-steroidal anti-inflammatories and physiotherapy. So that is low back pain. Very common thing. People come into your OPDs all bent over, not able to stand straight, and anything relating to the spine makes people very anxious. So it's important to tell them straight away that it's a good chance it'll all settle down and you'll be fine, and that itself makes them feel better. So the second one is chronic back pain. Now, chronic back pain is back pain that typically lasts more than 3 months and does not radiate down into the legs. In this clinical scenario, this is axial back pain, so it does not radiate down to the legs below the knees. It's aggravated by activities typically and certain postures, and the neurology is normal on examination. So the causes could be many. So it could be something as simple as muscle fatigue or poor posture. It could be arthritis of the facet joints or even disc degeneration. It could be spondylolisthesis or spondylolysis. Stress and anxiety also play a big part in chronic back pain and neck pain. And a lot of our patients who come to us with neck and back pain, if their X-rays and MRIs really don't show much, we get them evaluated by a clinical psychologist also. So patients with chronic back pain, I think it is worthwhile getting some scans and x-rays done to see what the cause of the pain is, instead of treating them blindly with NSAIDs or painkillers of any other sort. So you need to divide them into 2 or 3 different types of pain. Number one is the mechanical pain. So mechanical pain is typically dull aching. It increases with activity, is relieved by rest, and it does not usually radiate below the knee in the back, or if it's the neck, it's the elbow. So that is mechanical pain, as opposed to inflammatory back pain. So inflammatory back pain is typically more at rest. So these people complain of pain early mornings, and when they get out of bed, they have a lot of pain in the back, and it's typically relieved by activity, walking around a little, and then they start feeling better. It's exactly the opposite of mechanical back pain. The pain may be situated in the lower back, buttock, or the back of the thigh. And one thing to remember, if somebody comes with inflammatory back pain, is the possibility of seronegative spondyloarthropathy in the form of ankylosing spondylitis. And if it is very early stages, an MRI of the sacroiliac joints may pick up edema in the sacroiliac joint, signifying seronegative spondyloarthropathy. So that's something that you need to remember. So there's mechanical pain and there's inflammatory pain, and then there are the red flags. So the red flags, so anybody who, so low back pain is such a common complaint, but there are some that you cannot afford to miss. So anybody who comes with back pain below the age of 20 or above the age of 70 needs to be looked at a little more carefully. Anybody who comes with back pain following a significant fall or an injury needs to be looked at carefully. If the back pain is associated with fever or loss of weight or loss of appetite, you need to look at them a little more carefully to make sure that you're not missing out on any other pathologies. Worsening leg pain, numbness, weakness, and bladder problems are also red flags. Continuous pain at rest or night pain that disturbs people, disturbs the person, wakes them up from their sleep, is something that cannot be missed. And symptoms not settling with medications. This needs to be looked at a little more carefully. These are red flags. They may not mean anything, but you really don't want to miss out on any infections or tumors and things like that, which will benefit from early treatment. So these are the steps in treatment of chronic back pain. So in the early stages, there is definitely a role for physiotherapy if there is no deficits or things like that. So non-surgical treatment consists of predominantly pain medications, physiotherapy, and pain counseling. So if you think that there is an element of anxiety or stress, pain counseling definitely helps. Physiotherapy, exactly what type of physiotherapy we prescribe, we will get to later. And pain medications, if you're planning to give non-steroidal anti-inflammatories, a short course would be beneficial. If you're planning to give it for longer times, then you have other medications which are safer for long-term use. Spinal injections are useful in some instances, especially if you're looking at, if you think the pain is coming from the facet joints, spinal injections are useful, facet injections are useful. And if you have a surgically treatable problem like spondylolisthesis or spondylolysis, and if your patient has failed a trial of non-operative treatment, then surgery may be appropriate. The third case scenario, so we've discussed acute low back pain. We've discussed chronic low back pain, and the third one is back pain radiating down the leg. Now, typically, if you're thinking of a disc herniation, the pain should radiate in the dermatome of the involved nerve. So buttock pain and back of thigh pain are not radiculopathies. They're not radicular pains. Typically, these pains are aggravated by standing and walking. They may be associated with numbness and weakness in the leg. Disc herniation is probably the clinical diagnosis in this case. Lumbar canal stenosis is another diagnosis. So if you have a disc herniation like this, you can have radicular leg pain. You can have motor and sensory deficits as a result of the neural compression and the inflammation, or you can have a cauda equina syndrome. So we look at the natural history of leg pain itself. So this is Weber's paper from way back. So we know from the literature available to us now that the leg pain is a self-limiting condition. So in a majority of people, the sciatica pain settles down spontaneously. So if you go back to what Hippocrates said, so Hippocrates, although he did not know that the leg pain was due to a lumbar disc herniation, he thought it was because of a subluxed hip. He stated that a majority of patients have complete relief of pain in 40 days. So that's probably that 6-week mark that we talk about. And he advised, a wide variety of treatment options, including warm water application, fumigation, laxatives, and even donkey's milk. So lumbar disc, the sciatica pain or the lumbar radiculopathy coming from a lumbar disc herniation is a self-resolving condition in a majority of patients. Around 70 to 80% of patients settle down without any form of surgical intervention. So before we go into lumbar disc herniation, I think I'll just briefly go through some of these terminologies which we see on the MRI scans. So when they say on the MRI that the disc is normal, so if you're looking at the axial section of a scan, that means that there is no extension of the disc beyond the interspace. Okay. And if you look at the posterior aspect of the disc, it's concave like this. So that's a normal disc, it's not extruded. Whereas a disc bulge is, so that concavity that you see there in a normal disc is lost and it's more convex like this. It's circumferential and not just a focal. So it's circumferential, symmetrical extension beyond the interspace is called a disc bulge. Okay. So you have disc protrusion, so disc extrusion, and disc sequestration. All of them come under the term disc herniation. So a herniation could be a protrusion, it could be an extrusion, or it could be a sequestration. So protrusions are typically focal, not circumferential. The nucleus material remains within the outer fibers of the annulus fibrosus. Okay, so it is also called a contained disc herniation. An extrusion, on the other hand, is when the nucleus has penetrated through the annulus fibrosus and is contained and is gone right through and through the annulus and is contained just behind the posterior longitudinal ligament. And the sequestration, we know, is when the extruded disc is not in continuity with the rest of the disc or not in continuity with the parent disc. Okay. So the indications for lumbar discectomy are clear. So we know that a majority of them settle down. So the treatment, the indications for surgery are when there is a failure of symptoms to subside following a reasonable period of non-operative treatment, when there is a significant or a progressive motor deficit. So just a EHL weakness is not an indication for surgery. And if you have a cauda equina syndrome, that's an indication for early surgery or immediate surgery. And these are one of the few urgent indications for surgery in the spine. Oops. I think that's hello. Sorry, Mayank, can you hear me?
Yes, sir, I can hear you, but can't see your presentation.
Yeah, I know something's not right. Yeah. Just give me a minute, sorry.
Sure.
Sorry, just having, can you see my presentation now?
Not yet, sir.
Not able to share it. It's not.
So can you mail it to Mayank? Probably Mayank can show the presentation.
Okay. In the meantime, I'm happy to take some questions while we are doing this. Okay, okay. I think I've got it done. I've got it sorted. Sorry. Sorry, I think I've got it sorted. Yep. Can you see it now?
Yes, I can see, sir.
Okay, okay. So coming from lumbar canal stenosis, from lumbar disc herniation, we come to lumbar canal stenosis. This is a different pathology altogether. So we know that the pain in lumbar disc herniation, the leg pain is predominantly due to an inflammatory reaction that occurs near the nerves. We know that the lumbar discs, or disc for that matter, are avascular structures, and the minute the disc comes out of its place, the body doesn't recognize those proteins. And since the body doesn't recognize those proteins, it thinks of it as a foreign body. So there's an intense inflammatory reaction that occurs close to the nerve root, and that was what causes most of the leg pain. Lumbar canal stenosis is a different problem altogether. So lumbar canal stenosis is due to narrowing of the spinal canal. It could be due to vertebral spurs or disc bulging from the front. It could be due to fascial spurs from the side. It could be due to thickened ligamentum flavum or lamina enlargement from the back. And all this combines to reduce the space available for the neural structures. And this is what it looks like on the sagittal and axial MRI sections. You can see that this whitish portion here is all the space that's available for the neural structures. So it typically causes pain that radiates down the leg, and the pain is aggravated by standing and walking, and is relieved by bending or any action that flexes the spine, increases the space available for the spine, for the neural contents, and thereby reduces the pain. So activities that provide relief are bending forward and holding a shopping cart, or even cycling with the spine bent forward causes relief of symptoms, whereas when they stand and walk, they have pain, typically in the calves, is referred to as claudication pain, and prevents them from walking for long durations of time. So may or may not be associated with a neurological deficit. So the natural history of lumbar canal stenosis is a little different from lumbar disc herniation. We know that lumbar disc herniation, like I mentioned earlier, has got a favorable natural history. A majority of them settle down. But lumbar canal stenosis, the natural history is not very favorable. So that means that if you do not do anything, it has been shown that a majority of patients continue to remain status quo. So surgery has been shown to provide greater improvement in symptoms. but a majority of non-operative symptom patients did not worsen. So this is from the sport trial that came out. So how does that affect decision making is that if the patient has got severe symptoms, then it's worthwhile offering them surgery, or if they've got deteriorating symptoms, it's worthwhile offering them surgery. Whereas patients with mild to moderate symptoms, non-operative treatment can be offered. So it is important to remember that a majority of patients continue to remain the same. A few of them worsen, but very few of them actually get better. So that is the natural history of lumbar canal stenosis, and surgery would be some form of decompression surgery. So we come to non-operative measures. So a majority of our patients require non-operative treatment, isn't it? So a lot of the back pains and the neck pains require non-operative treatment, and we speak very little about this non-operative treatment. Most of our conferences deal with surgical techniques and surgical indications. There are very few talks on non-operative measures. So we just look at 7 or 8 non-operative options that we have. So bed rest is not a great option for any kind of spinal condition. So if they have severe back pain or sciatica, enforced bed rest is rarely required. So you should not tell them. There is no advantage in telling patients that they need to take complete bed rest for a week or 10 days or 3 weeks or however. So there is no great difference. So this Cochrane review has shown that there is no big difference in asking patients to stay active versus bed rest. So what we tell most of our patients is we allow them to do whatever is possible for them within the limits of their pain. So we don't enforce bed rest, and strict bed rest more than 48 hours has been shown to be detrimental. The second one is traction. This was a hot favorite in the past, but popularized by Hippocrates himself. There is rarely any indications for traction for spinal conditions. So the only time we use a bit of traction, which I use a bit of traction, are severe scoliotic deformities when we apply some traction, in-hospital traction, continuous traction for a couple of weeks before surgery. But as a pain relieving measure, I don't think there is any role for traction anymore. Now coming to physiotherapy itself. So back exercises, core stabilization exercises are a good option for neck and back pain and acute and chronic pain. Regarding electrotherapy, shortwave diathermy, ultrasound, TENS, there is hardly any evidence to say any of these work. Most of the people I work with, at least, I haven't used this for more than 10 to 15 years now. And even physios, when you speak to physios, they also are quite reluctant to use electrotherapy because there is no evidence that it actually helps. Medications, NSAID is definitely the first line of treatment. Don't think there is any evidence that one NSAID is better than the other. I do try oral steroids in patients with cervical disc herniation, just because the complications associated with cervical nerve root blocks are slightly more than that associated with lumbar nerve root blocks. For lumbar disc herniation, I use nerve root blocks, but for my cervical disc herniations, I give them a tapering course of oral steroids, so that is an option too. Anticonvulsants like gabapentin and pregabalin is something that we use a lot for neuropathic pain, and so is amitriptyline. Fluoroscopy guided steroid injections, excellent option for lumbar disc herniations, and gives nearly immediate relief. So we looked at our series of patients who had lumbar disc herniations. So we give them lumbar disc herniations very early in their, usually in the first or maximum the second visit, we give them a lumbar disc, nerve root block. And we looked at the temporal pattern of reduction in pain, and we found out that there is a 70 to 80% reduction in pain within half an hour of the injection. So I think it's an excellent option, and it's worthwhile doing it early. You save, you save the patient so much of suffering and pain and disability as a result of this. The complication rates are very, very low. So this is what the evidence currently shows us. So exercises, multidisciplinary rehabilitations, there is definitely evidence for that. Spinal manipulation and massage may be a transient effect. Traction and ultrasound and other forms of electrotherapy are clearly ineffective. Acupuncture and hydrotherapy, hydrotherapy, warm water pools are a good option in elderly people and people who suffer with back pain, but acupuncture we don't know. So the way I work with my physiotherapists is that I don't tell them what to do. So I send them for the physiotherapy and let my physiotherapists take a decision on what kind of physiotherapy modalities are going to be useful for that particular patient, and it's based on the assumption that they clearly know more physiotherapy than I do. I clearly don't know much physiotherapy, being a surgeon, and so I've chosen good physio. I work with a team of very good physiotherapists, and they decide what kind of treatment the patient requires. And most of the time, they are offered something called manual therapy and exercises that some of them get some dry needling also, but no electrotherapy. And our physiotherapy sessions occur once or maximum 2 times a week, and that goes on for 4 to 6 weeks. So that's how we treat our patients non-operatively.